All right, good job. Mechanism of action, proton pump inhibitors to reduce acid secretion in the stomach. Proton pump inhibitors do not block H2. That's histamine blockers. So the proton pump inhibitors just reduce acid secretion. And you say, wait a minute, H2 blockers block acid secretion too. Yes, they do. But proton pump inhibitors actually physically stop acid production. They do not block the H2 receptors. So the H2 blockers are those right there. So proton pump inhibitors do not block H2 receptors. They physically actually change the stomach cells from producing acid. So decrease acid in the stomach. Ooh, right in the middle there. Remember, proton pump inhibitors, how are they similar to receptor blockers? They both prohibit hydrogen acid or the hydrogen ion, the hydrochloric acid release from the stomach. One works on histamine receptors, the other works on gastrin receptors. So they're similar to each other in that they both stop acid production. They work differently. The ones that work as pH buffers are antacids with bicarb in them. They're the ones that that neutralize the pH of the stomach acid. Okay, so just a little bit of patho behind those meds there. We learn as we test. I'd rather you learn in practice tests than learn on the real test. I think that's supposed to be soften your stool. Good job. Got all the antacids down. All right, I think we're moving on. Nope, maybe not. FYI, now you know, side effects of proton pump inhibitors is a headache. So if you did look that up in your drug book, most proton pump inhibitors will have a headache. Just little known things to learn, things to know. Good job. The Zols are proton pump inhibitors. The Deans are H2 blockers. And ranitidine's been thrown away now. It's one of our primaries that now is no longer existing. But ranitidine is an H2 blocker. Omeprazole, pantoprazole, all those azoles are proton pump inhibitors. So if anybody comes up with a mnemonic, let us know. We'll put it in shared notes. Calcium carbonate would be an antacid. If it's, I think it's an antacid. Aluminum hydroxide is an antacid as well. Not as commonly used. Good job. We should have pictures, right, on all the tests? Wouldn't that be easier? Smoking is a risk factor for GERD. It irritates, it causes esophagitis. These are the questions you wished you had on your test. It's gastroesophageal, GE, gastroesophageal. So we're refluxing into the esophagus from the gastric. Gastrointestinal reflux is actually where it would be influxing from the duodenum back into the stomach. So gastroesophageal reflux. Some of these are too fast, I'm sorry. Add more pillows. So GERD, if we sleep flat, supine, that is going to cause it'd be very easy for gastric secretions to get into the esophagus. So they usually sleep more upright and do not eat before bed. So put more pillows behind your back. Get your gravity working for you there, keeping this fluid in the stomach. So add more pillows. Good job. I mean, you know, Taco Tuesday, and when you eat your feelings, I mean, if you're eating too much, you could get some GERD, but the overall answer that includes Taco Tuesday and when you eat your feelings is when gastric acids damage the esophageal mucosa. So even though you love Taco Tuesday and love eating your feelings, they both can cause GERD. The over-encompassing answer that covers both of those, it's an umbrella answer. Gastric acid damaging the esophageal mucosa would occur even on Taco Tuesday and when you eat your feelings. So it's the umbrella answer. It's the best answer. Even though I would pick Taco Tuesday because that's when I get GERD. Good job. They don't bind with stomach acid. They actually, H2 blockers just bind to that receptor site, that histamine receptor site in the stomach, and that histamine receptor site is responsible for stimulating acid secretion. So when they bind to that receptor site, they prevent acid secretion. So that's how they work. Again, I'm not testing you on that, but just thought the more you know, the more you learn. Good job. Ranitidine is the H2 blocker. Calcium carbonate, someone did point out, is Tums, is an antacid, and that does not bind to histamine receptors. So just kind of getting you familiar with the names of the drugs and the drugs. Apparently, I have found a lot of these. Good job. Y'all got it right. Y'all know what that's for. I think we can move on, except that I got a little bit trigger happy when finding all these questions. Good job. The azoles are the proton pump inhibitors. So all of the dienes are H2 blockers, and the zoles are proton pump inhibitors. Oops. Ah! It was, I can't go back to it. I hit the next one. I was trying to clear things out because it was going to take too much time. It looked like most of you hit the correct answer on that one, and I just forgot the question. I don't even remember what it was. Oh, well. You can go back and do it again. I'm sorry. My short-term memory's gone. Oh, which condition was caused by H. pylori? Okay, thank you. That other one was peptic ulcers, yes. And the most sensitive test is the breath test. Stool culture is there, but the breath test is more sensitive because it's really just, it's checking for the disintegration of that H. pylori eating up whatever they've given you and creating some compounds. And so the breath test is very sensitive for H. pylori. I don't know why there's a baseball picture on this one. Don't ask. All right, bacteria causes an ulcer. What is the word, what does the word dyspepsia mean? It's for anybody that maybe didn't pick it because they didn't know. Upset stomach. Yep. We have all kinds of fancy words, but upset stomach. It is bacteria. And so it could, people could argue that it causes dyspepsia, upset stomach, but dyspepsia is such a vague word. The bacteria causing an ulcer, that's exactly what it does, is it breaks down our mucosal barrier and causes ulcers. So dyspepsia, I'm glad nobody chose it, but it might be because they didn't know what it was. It just means upset stomach. It's very vague, like nausea, vomiting. Oh, it's a multi-select. Let's see how that works. Did it work? Could you choose two? If it says multi-select, you should be able to choose two. Yay! So now you can get more points for choosing two. You could probably choose all four, but you will be able to see the correct two now. They will still be marked. I think you get, I don't know if they gives you partial points or what it does. But anyway, yeah, I'm like, yay, now we can choose two. So you can see the correct answers are anticoagulants and nonsteroidals can lead to GI bleeds. Nonsteroidals and aspirin because they actually break down your mucosal barrier in your stomach, causing you more ulcers. And anticoagulants, they can lead to GI bleed by if you have an ulcer that bleeds, then you won't stop bleeding if you're on an anticoagulant. So these multi-selects may get people good at select all that apply. Oh, another multi-select. How exciting. Oop, where'd I go? Perfect. So you got all three. Yay, CBC, because we want to look at the H&H. These are just diagnostic procedures you would do with GI bleeds, diagnostic labs, diagnostic things. You would want to know your H&H. You would want to know how your coags are looking, and you would want to get them to endoscopy or colonoscopy. Good job. Another one. I got excited, I guess. Good job, guys. Okay, Xylate is for potassium excess, kalemia, potassium excess. Lactulose is for ammonia. And yes, endoscopy and NPO with packed red blood cells is for esophageal varices that are acutely bleeding. All right, we're not multi-selecting anymore, all except. Good. We probably, if you are bleeding, acutely bleeding from your GI tract, you could have bleeding vomit. Melena is dark tarry stools. Tachycardia is an increased heart rate in response to low circulating volume. And increased urine output, probably not likely because you are lowering your vascular circulation. You're probably just going to start retaining your urine. You're going to start holding on to urine. Getting dehydrated. Good job. That was a lot of reading. You got through it. It works by promoting vasoconstriction of GI cells, which kind of causes a decrease in blood flow to the area and a chance to clot off. But it does not it's not a coagulant. It doesn't go on and actually, stop bleeding like a little peptide, like one of those like sticks that you put on your face after you shave or whatever, or you have a bleeding. It doesn't make the source of bleeding clot off directly. It constricts the vessels and causes some decrease in blood flow that way. Oh, another multi-select. So actually, this is miskeyed. I'm sorry. It shouldn't be all of the above. If it's an upper GI bleed, it should not be passage of fresh blood per rectum. So if it's an upper GI bleed, I think this was originally GI bleed. I didn't read this one. I changed it too much. I will fix this one. I'll make a little note to fix this one. I think I changed it to upper GI bleed in the question, but then didn't rekey the answers. It should be red and blue. It should be vomiting blood or melena black tar-like stool. So I will fix this answer for when you practice your test. Upper GI bleed will only be vomiting blood or melena black tar-like stool. It will not have fresh blood for rectum. You're bleeding from your esophagus or your stomach, not your rectum. So it shouldn't be all of the above, and it shouldn't be hematochezia, which is passage of fresh blood from the rectum. So it should only be, so U11 that got both of those red and blue, those are the correct answers. I will fix that one. Sorry for the way it probably messed up the standings here. But O's still on top. Nobody moved. Okay, well, so it didn't mess up standings too bad. Not a priority. You might not know one vocabulary word on here. All right, that went too fast. And I will, when I go send these out for you to practice with, I try to get them all to 30 seconds or more. So this one, let's kind of talk about dealing with a patient with GI hemorrhage. So they're bleeding, GI bleeding, which is not a priority. Not a priority is sitting them straight upright because they're going to be orthostatic. They're going to be not, sitting them straight upright could cause dizziness. You would want to lower their head of the bed if they are bleeding out. The other reason you probably didn't know the correct answer, and I could change this to something else. Positive inotropic meds are meds that increase the squeeze of your heart and help your heart circulate better. You don't know that word yet. We haven't gone over that, so probably not fair to give it to you. Positive inotropic meds are things that help your heart squeeze and help your heart deal with a low volume. And so, of course, it is appropriate if you knew what it was. So I don't fault you for that one. You could give positive inotropic meds. Some of the common inotropic meds, in case you've seen them, are dopamine, dobutamine, and digoxin. If you see all these, we talk about them more when we talk about heart failure. But dopamine, dobutamine, digoxin are inotropic meds. And they could possibly give those to help the heart deal with the lower volume. But sitting them straight upright at 90 degrees could lead to dizziness. So I'll either fix this question or send it out there. But now you know a little bit more. Oh, this is too fast. I'm sorry. That was true. Octreotide can also reduce blood flow, which is what we give it to, but they have found that it does inhibit gastric acid secretion, which we're like, yay, that's great. When you have a bleeding upper GI, you don't want the stomach producing too much acid. So octreotide does have a little bit of an antacid effect to it as well, but we're still going to probably give H2 blockers or proton pump inhibitors on top of octreotide. But just so you know, it does do both. Kahoots for learning. I'd rather do it now than after an exam. Sorry for people that it's too fast for. I should slow these all down. I usually check on them before I try to post them, but I was doing it late last night. I'll slow them all down for your study purposes. Upper GI bleed is coffee ground colored because the blood has been mixed and changed by the acid in the stomach. So that is why it is coffee ground colored. Blood is mixing with the hydrochloric acid in the stomach and getting curdled, basically. Black and tarry stools. Upper GI bleed takes a long time to get out, so they will have black and tarry stools. Tarry meaning thick and sticky, not just black, but sticky and that gelatinous. I mean, sorry, that's a beautiful picture of a black tarry stool. It is gross and gelatinous and almost looks like some thick clots with some stool that got stuck in it, but it is foul. Ugh. Black and tarry. Go eat lunch now. Yeah, it is kind of gross. This gelatinous blob. So GI bleeds can cause postural hypotension, orthostatic hypotension because you've lost blood volume, so you're dehydrated, you're looking a little dizzy. Ulcerations cause GI bleeds. GI bleeds don't cause more ulceration. And GI bleeds, they can cause inflammation, but they're much more likely to cause blood loss and postural hypertension than an immune response. Bleeding doesn't actively cause an immune response right away. It will as we try to eat up old destroyed red blood cells, but it's not going to cause massive inflammation really. GI bleeds mostly cause orthostatic hypotension or dehydration. Got the same top 5 here. This one's for everybody. And I guess I could probably even do a select all. Good, you went for hematocrit. Some of you could go with bun, and you could argue because it is part of the scaling. We will watch it, but we're going to see the hematocrit drop probably before the BUN rise. But I would take BUN. I probably wouldn't put that so much because BUN is part of what we're monitoring to classify major versus minor bleed. But we wouldn't look at it before we would look at hematocrit. We're really going to be looking at hematocrit mostly. But I would take BUN. I wouldn't fault you wrong for that. That means you listen to me. I appreciate that. All right, good job. All the other ones can contribute to GI bleeds. Colon cancer can have, those tumors can lyse and bleed. Ulcerative colitis, definitely. Crohn's disease, yes. And diverticulosis, ISIS, yes. All of those little guys can bleed. The intestinal lining is full of blood vessels. So a couple for colonoscopy. Preparing a patient for a colonoscopy would be a nursing intervention technically. And administer any prescribed blood products, of course, great intervention for upper GI bleed. It's usually the treatment for a large bleed. Fluid restriction, not quite. We would give fluids, not fluid restriction. I don't like those kind of semantics things about nursing interventions versus interventions, but multi-select. Actually, is it a multi-select? I don't know about that. This was not a multi-select. It was mislabeled. But we can talk a little bit about it. Definitely a lower GI bleed. So they're going to go lower and do a colonoscopy. We could prepare them for a colonoscopy. Octreotide or sandostatin is good for an upper GI bleed. Upper GI bleed. It only works on stomach and esophagus blood vessels. It doesn't work on lower intestinal blood vessels. Vasopressin is the only IV med that is possibly available for that. Lower GI bleed, no octreotide, only with upper GI bleed. Warfarin right out, because that is anti-clotting. And elevate the head of the bed. Again, we don't usually put their head of the bed up if they have a risk of having a low blood volume. We'd probably want to lower their head of the bed. Elevate head of the bed is for breathing problems, not so much for if you are low blood pressure from a GI bleed. So colonoscopy is the answer there. That was not a multi-select. I think I got excited about multi-selects. Sorry about that. So this one's kind of all over the board as well. This would go with any autoimmune disease. Everyone should probably stop smoking. I get that. And aerobic exercise is great. And weight reduction is great. Those are all good. But during an exacerbation of an inflammatory disease, we want to minimize the amount of stress during the exacerbation time. So stress management would probably be the best answer here. Again, this is not my favorite question, but I did want to talk about it. When we are exacerbating any autoimmune disease, we try to reduce stress. Stopping smoking will actually increase your stress response. It's a good idea overall, but probably not the best timing when you're in an exacerbation of an autoimmune disease to try to start an exercise program, stop smoking, make big changes in your life during an exacerbation. So that would kind of go with any autoimmune disease, whether it's one of the, maybe we're talking about myasthenia gravis, multiple sclerosis, those autoimmune diseases of the nerves. That's not the best time in the world. When you're exacerbating, it's because you're already under some kind of stress or illness. We probably don't want to be including. So that's the argument for this one, and the rationale is that yes, it's a good idea to stop smoking. It's a good idea to exercise more. It's a good idea to make sure you don't have extra weight on you. But during exacerbations of autoimmune diseases, we focus on stress management and decreasing triggers. Does that make sense to people? I wanted to put that out there. Like I said, not my favorite question, but something when you're looking at NCLEX questions and rationales behind it, something that would go for something that will make things worse. And if you start exercising, that's going to increase your stress load on your body. Smoking cessation is going to increase the stress load on your body. Weight reduction or diet changes, especially if you don't need them. With Crohn's disease, they already are a little bit malnourished. You shouldn't be doing weight reduction. But stress management is the cornerstone for a lot of autoimmune diseases. Yeah, this one was a tricky one as well. This is something further teaching. So a wrong answer about Crohn's. They will need to add calcium, iron supplements. A high fiber, high protein diet are good. We would like you to be moving things through your bowels. High protein, again, gives you lots of good, things. Yeah, it's just those misreading things. Soft bland diets do benefit during flare-ups, but you don't want a Crohn's patient losing weight, and their diet shouldn't help them lose weight. That's something they shouldn't be aiming for. They're dealing with a lot of malnutrition because their intestine is not absorbing. So you want to make sure it's high fiber, high quality diet with lots of supplements and extra protein so that we can absorb somewhere along the tract. We'll do a couple more. I do need to end before 2 because I have meetings starting at 2 with block 4. So I won't get all the way through them, but we'll get most of the way. Good job. You didn't fall into the trap. A lot of people would put bowel obstruction because they know it goes with Crohn's, but that's not a common symptom. That's an unexpected worsening occurrence. So when you're seeing common or most common, you're looking for expected things. If you're going for any of the worsening conditions like a GI bleed, bowel obstruction, those would be worsening conditions. And left lower quadrant pain, variform stool, and obesity are not Crohn's disease. It's the opposite of Crohn's disease. Inflammation. This is the GI specific anti-inflammatory sulfasalazine and mesalamine. I can't say them all. But those are our GI specific anti-inflammatories. And then we will move up to corticosteroids during severe flare-ups. So that is what it treats, is inflammation. Correct, false. Ulcerative colitis is colon only. Crohn's disease is usually some small, some large, but can be all over the gut. Ulcerative colitis is colon only, usually the end of the colon. So they're usually different places. Good job. It's between Crohn's and ulcerative colitis. What we're doing in the colon is really reabsorbing water and electrolytes, but we're doing most of our in the small intestine, the end of the small intestine, beginning of the big intestine. That area of small intestine is doing most of our protein. They're doing proteins, fluids, vitamins, minerals. All those things are getting absorbed in the small intestine. So Crohn's disease has the most risk for malabsorption. Ulcerative colitis will decrease our absorption of water, electrolytes, a few vitamins and minerals. But Crohn's disease will affect most of our nutrition. That's where most of our nutrition gets reabsorbed, is in the small intestine. And that's where Crohn's usually is. So it can give you constipation alternating with diarrhea, pain, cramps, swelling. I would probably have taken all of the above for it. It's not usually associated with weight gain. There really isn't a big difference in your weight with it. In fact, most people don't feel good enough to eat very well. So it's not really associated with weight gain, but definitely with constipation and pain, cramps. So if I changed the weight gain to diarrhea, they would be, all of the above would be correct. So I might change that one and make it a little bit better. There's definitely pain, cramps, and yes, constipation is a symptom of it. So I could see why you chose all of the above. I'll switch weight gain out for diarrhea. So you have constipation, diarrhea, and abdominal pain. Abdominal pain. Good job. We're kind of in between the two. Crohn's disease, cobblestone in appearance, because that's the scar tissue, extends through the entire bowel wall, changes the whole bowel wall, can also form fistulas. Ulcerative colitis is smooth, clear, full of ulcers, only deals with the top layer of intestine, so basically sloughs off the top layer of your intestine, so not through the entire bowel wall, just the top part of the bowel wall, and can cause ulcers, basically. So you're sloughing off the top wall, whereas the cobblestones and entire bowel wall is Crohn's disease. And irritable bowel does not change your bowel wall at all. It's a problem with muscle contractions. So important distinctions to make on those. Irritated bowels right up there on top. I think this will be the last one, and then I need to sign off, and I'll let you do the rest on your own. That one was too easy, wasn't it? True. It does. Disease of the colon, yes. Formation of ulcers, yes. And then abscesses. It can form abscesses. If you had an open sore and you put a piece of stool on it, it's gonna get infected. And that's what's happening in that ulcerative colitis, is you have an open sore and we are now just pushing stool past it. It can get infected and abscessed as well. So the abscesses do form in ulcerative colitis. All right, O's at the top. I'm going to let you guys go at question 40. There are 30 more for you to play with. So I'm going to let you go.